Hi, and welcome to Healthcare Simplified with Manvir and Richter. And today we are very proud and honored to have a great guest with us right here, talking to you, unpacking some elements of healthcare that we all need to in our daily lives. It's someone that I just realized that I've known for about 15 years of my journey as a patient and a patient advocate. We have the person who has steered us through the darkest parts of Malaysian healthcare. The one, the only, Sri Dr Noor Hisham. How are you, Sri?
I'm good. Thank you, Manvir, for having me this afternoon. And I'm happy to be here and to engage with you again after 15 years.
No, we have been in these past 15 years. I've learned a lot from you. And I just want to relate to everyone that story,
Yes,
because the first time when I met you, you were a surgeon in
yes,
Putrajaya,
that's
you're
right.
the Deputy Director of Health,
That's right.
PG of Health. Then
Mm.
I didn't know all these things. I went to you for a consult to do a operation. And after you explained to me everything on an iPad in
Yes,
2010,
that's right.
which I thought was amazing then,
Mm-hmm.
doctor knowing how to use the
That's right.
iPad. And then after that, you asked me, have you got any other questions? And I looked at you and I said, I'm not sure. I can't think of any.
Yes,
And you handed me your phone number and you told me, yeah, if you feel anything, if you have any questions,
that's right.
please do text me and
Yeah.
ask me these things. And so that really started our relationship because that time already,
Mm.
you already believed in building a trust, a
That's right.
relationship with patients.
Yes.
Right? And that has really resonated. And you have, from a one to one kind of a relationship, you have managed to build that relationship with millions of Malaysians
Yes,
through social media.
that's right.
And where did that come from? That's not your doctor part.
Well,
Is it necessary?
that's come from our training. I think most important is that you as a surgeon, you're trained to engage with your patient. And obviously, when you engage with your patient, you discuss the issues and challenges, and you manage the expectation of the patient. And the patient have a lot of questions, so you
Right.
try your best to answer all the questions.
Right.
So if you can manage the expectation of the patient, then you win the patient's trust.
Right.
And more so, then they know what to expect to go for the surgery and after the surgery, etc. Likewise, in public health, the same thing. You try to manage the public expectation.
Right.
So, and a lot public have a lot of questions
Right.
regards to all the issues and challenges. So, if we can manage the expectation of the public, and then we can win the public trust. I think it's almost the same. Being one patient when we engage before the surgery, and also in the public health issues when there's a lot of uncertainty.
Right.
So this is important for us to make sure that we spend time understanding the patient,
Right.
manage the expectation of patient, and win the public trust.
Absolutely, because I think that's the key thing about healthcare, that you cannot guarantee an outcome.
Yes,
But if you build that trust,
yes,
then the patient knows that you've tried your best.
right.
You've done everything.
Exactly.
that you've
That's
done.
right. Yeah, true.
That's it. So now I want to ask you this question because you've been retired 2 years now,
Yes, 2 years, more than 2 years now.
more than 2 years now. So you are obviously a stalwart of the public system. You've gone in through as a doctor, houseman, all those years, EG,
Yes, right.
and took us through our darkest periods. And now you're in private.
Yes,
And now that you've been in private for about 2.5 years,
yes,
you've seen the other side.
yes,
And you are at UCSI University
yes, right.
Hospital
That's right.
in Spring Hill. What do you see the difference or the similarities between our public and private health?
Well, after retirement in April 2023, I gave myself a grace period of 6 months,
Okay.
right, not to take any job in the private sector. So after 6 months, I was offered to lead the UCSI healthcare group, and also later I was offered by the government to become the chairman of the IJN board, and also I took up the offer as a chancellor for University of Cyberjaya. So I think that I could contribute more so in UCSI because it's a hospital. Apart from managing the hospital, but I'm also providing my services, run my clinics and do the surgery and etc. in UCSI hospital. So it's a bit different because we have the experience in the public sector, but now in the private sector, I feel that private sector has been neglected Because when I was a DG, as a DG, I think we focus mainly on the public sector.
Okay.
But now that we realize that, private sector is equally important,
Okay.
you need to engage both sectors. And COVID-19 actually have taught us important lesson, and we need to leverage on the lesson learned from the COVID-19,
Okay.
strengthening our health system, public sector, private sector.
Okay.
That's why we embrace the whole of government and whole of society approach.
Okay.
And for the first time in history, we knocked down the wall between the public and private, trying to integrate the services, optimize our resources in the public sector and private sector.
Okay.
For example, most of the infected COVID patients will refer to public sector. The non-COVID elective cases, we refer to the private sector.
Right.
And private sector loaned us ventilators and etc. More than 1,500 to 2,000 staff from the private hospital crossed over to public sector to provide service pro bono for 6 months, for example, during the peak. So we integrate very well between public sector, private sector at that point of time. So I think that is a lesson learned on the hindsight. If we can integrate the public and private together,
Right.
I think, and optimize the resources,
Right.
by manpower and etc., I think we can make a big difference in healthcare.
Okay. So very interestingly, it segues into this next question that I have for you. Currently, Malaysia, we're talking about this Rakan KKM, where a private facility in a public facility. Now, at UCSR, you've done the reverse.
Yes, that's
You have a private facility and you have a public wing to it. Can you explain a little bit about that?
Now, when I was in the public sector, so we have a retention package for our specialists, but not interrupting the services to the public,
Okay.
V40, for example. So our idea is after 5, for example, can we allow our doctors to use the operating theatres and etc. to make a side income, or during the weekend, Saturday and Sunday. So our specialists, they can volunteer to work on Saturday. It's their own time actually,
Okay.
and they make some money from that. So that is the incentive that we give to them,
Yeah.
but not compromising the care to the public sector. So we make sure that their care is not more than 30% for the public,
Okay.
for the private sector. So after 5 or Saturday and Sunday. And also we allow our specialists 1 day a week to do locum in the private sector.
Okay.
So that is a policy for retention package. So our doctors are happy, our specialists are happy with that. As they can't compete with the private, at least they can make some income from this practice. But it's still a public sector. So we
Sure.
call it a full paying patient.
Good paying.
Right. So not compromising the elective list for the public patient.
Okay.
So this is after 5 or during the weekend.
Right.
So now in private sector, we then realize that, why can't we have a public wing whereby this public wing, and then we look into the fee, professional fee and non-professional fee. Professional fee has not been revised for the last 19 years.
Yes.
Right. Non-professional fee is the one that inflation coming in is escalating, is a non-professional fee. So we spoke to the management, perhaps we can give a discount on the non-professional fee. But we also talk to the specialists, we are not forcing them to give a discount, because if we force them, that will be a fee splitting. That's
Fee
wrong.
splitting, yeah.
But if they want to give a discount, that's fine.
Yeah.
And now we realize that, in private sector, 90% of the fee is the non-professional fee, 10% of the fee is the professional fee.
Okay.
Then the hospital will ask the specialist whether they want to give a discount or not. So that's our record, whether they want to give the discount.
And the quantum is decided by you.
Quantum is about 30%, 30 to 40%.
Okay,
Yeah.
at least.
So all in all, we can reduce the cost of treatment. Because it's in private sector, everything is you have to pay, right? But at least a reasonable fee. So high impact, good outcome at a reasonable cost.
Okay.
So we think that the reasonable cost is affordable.
Okay.
For Malaysian, especially those not insured, and have to pay out of pocket, for example. So I think only thing difference is that they don't have a single room. They have to share 4 bedded, for example, with one single toilet. And things like this, but the doctor's the same, the operating room is the same. Yeah, that's it. Yeah.
So this is now available to just about anybody, or is it a certain segment? Because it's the Rakyat wing in UCSI.
This is a Rakyat wing, or we call it a public wing in UCSI. Basically, for those who cannot afford.
Okay.
Those of B40, for example, we will check them out whether
Okay.
they qualify. If they can afford, definitely they go for the private side.
Okay.
Yeah, just like private hospital. But if they cannot afford, need assistance, that's where we have funds and to assist them to come in, to come to our hospital for the treatment. Yeah.
And you said there's a fund, then you have a fund for
Yeah, yeah.
How's that work?
There is actually a quota that we have,
Okay.
allocation for the public wing. I mean, a year, how many we can actually sponsor and subsidize.
I see. Okay.
Yeah.
So these are for deserving people. right?
Deserving poor patient.
So take me to that patient journey for someone. So a B40 patient
Yeah.
goes into the hospital.
So, for example, I have a patient, breast cancer patient, diagnosed in February, then delayed in terms of deciding to do the surgery. Came to me, and then obviously I want to offer as soon as possible, but she doesn't have insurance, not uninsured,
Okay.
and she told me that out of pocket payment is so that cannot afford the private rate. So when we offer her the public wing, so she could afford, like she can actually manage to get the funds. It's about 40% discount of
40%.
Yeah, yeah. Mm.
Okay. So she's able to do the operation,
Yeah,
save her life, get better.
that's right. Yeah.
Okay. So this is does this for this person breast cancer?
Breast cancer, that's right.
So will that also include the oncology treatment or
Yeah, that's also come under public wing.
under the public wing?
Yeah.
So basically now this happens at UCSI in Spring Hill,
Yeah, it's Spring Hill, that's right.
and people can just Google it and find.
But
out.
this is not a new concept. In Indonesia, for example, their
Okay.
private hospital, they do have a public wing.
Okay.
So only in Malaysia, I think this is the first time that we are implementing it.
Okay.
But I've been to Indonesia, their private hospital, they have a private wing and also a public wing in the private hospital.
Okay.
So now we are emulating and starting this journey of offering public patients, public wing in our private hospital. I
Absolutely.
think that is strike the balance. So we need learning from COVID-19. We try to optimize the resources, public sector and private sector.
Okay.
How can we contribute? Because we have to pay everything, but then optimize the resources and the minimal minimal cost like that for the patients. I think this is where we try to provide the services to those needy.
Do you think that other private entities should emulate this, and are they able to do this?
I think it's good for other hospitals to follow suit as well, because this is not a new concept. This is a concept being practiced in Indonesia. But we are also looking into, in the past, for example, private hospital accepting public patient.
Okay.
So, for example, radiotherapy, there's only about 5 radiotherapy center in the public hospital.
Right.
And those days, we send our patient to private hospital for treatment. I think that was 5-10 years ago, to Nilai Cancer Center and etc. And the government pay for it. Ministry of Health pays the services. So even now, like for example, waiting time for cardiac surgery in Sedang Hospital, like more than a year, and elective, more than 800 patients are waiting for elective open heart surgery.
Right.
So the government have funds to actually outsource to the private hospital.
Right.
So now I think 3 hospitals been identified: UCSI, Thomson Hospital, and and another I'm not sure another one hospitals been
Right.
3 hospitals IJN 3 hospitals been identified. So and paid by the Ministry of Health
Okay.
at a flat rate. Right. So the negotiation of the rate is ongoing. So that is good to decongest some of the patients from the public sector. So we already have a public wing in that sense,
Right.
directly. And the cost is actually a flat rate because, for example, open heart surgery, we negotiated a rate that is a minimal cost as compared to a private patient.
Okay.
So that's already ongoing.
Right. And you think this kind of a model would be sustainable?
The effort comes from the private hospital. This is part of charity organization. Like for example, the outsourcing of cardiac cases coming from Sedang. Initially, we are making a loss actually. We're looking into it. So we need to renegotiate the rate so that we break even and slightly make a small income. Right? So, yeah. So I think this is an ongoing kind of cases. So, but I think this is something that we try to integrate public sector and private sector working together towards a healthcare, how do we optimize the resources in public sector and private sector. And COVID-19 have taught us to integrate the system,
Sure.
public and private. And this is what we are doing.
Yeah, you bring up a good point because healthcare as it is, there are a lot of people who are against profit in healthcare because they say it's a human right.
Yeah.
You have to deliver it, and it's unfair as well on any government to look at it from just giving it free
Yeah.
as opposed to charging a lot of money for it and making profit. So where is that? I mean, you have worked in public and now in private. Where do you see that fine line of that tension?
Well, we need to strike a balance. In the public sector, everything is sponsored by the government, right? So, but in private sector, you have to find the funds to be sustainable.
Absolutely.
So you need to strike a balance in the cost, So our, tagline is how do we provide, good quality of care, high impact, good outcome at a reasonable cost.
Okay.
So that is the thing, reasonable cost.
Right.
So there will be a cost in private sector.
Of course.
It's not free because we are not subsidized by the government. So that reasonable cost is we try to optimize it, in terms of, strike that balance that patient can afford and also provide good quality care. I think waiting time is less and etc.
Do you see, I mean, because of your international exposure globally, you've been with so many organizations, including WHO. Do you see other systems where public does decant their patients onto private as well to help?
Yeah, I think in Ministry of Health, we have actually practiced decant our patient to the private sector a long time ago.
Okay.
Since I took up the office of as a DG, we send cancer patient, to a private hospital for radiotherapy and treatment and etc. So it's not new. The concept is not new. Just that in the public sector, we been doing that, but now in the private sector, we have a public wing.
Okay.
So we extend the services more widely, not only for cancer patient, but widely for surgery and etc. So at affordable price. Now, in the private sector, certainly waiting time is less.
Sure.
And very rewarding to practice in the private sector because when patient comes in, within one day I can do everything, mammogram, ultrasound, biopsy, and I can get the report tomorrow, for example. So not in the public hospital because you need to queue for ultrasound, you need to queue for mammogram, biopsy, and all that. By the time you get all the reports, it's already 2 or 3 months late. So
if at all.
Yeah. But in private hospital, everything can be done within the same day or even the day or two. In fact, recently I have a patient came to see me in the clinic fasting and saying that he has a nodule there. I want the nodule to be done this afternoon. So I know. So I'm more than happy to do the operation the afternoon because he already fasted. So we can do the surgery and then discharge the patient tomorrow.
Oh, wow.
So I think this is one advantage of healthcare in Malaysia. If you ask anyone in UK or, they have to wait a long appointment to see a doctor. Here in Malaysia, you can see the specialist anytime. And more so, we can give the operation, there's no queue for surgery, very short queue. And then we can do the surgery as soon as possible. It's very rewarding to get, to practice in the private sector. For example, if I do an operation today, in next 5 days, I get the report ready. HPE report should be ready by 5 days. So, and I can engage with the patient, faster, better. So how can we do things faster, better, smarter, safer, and obviously, if we can do it cheaper, I think that's the way forward.
Now, you were talking about this a bit earlier. You were working and then you took a 6-month break after you retired before you chose a hospital to move into. And you chose UCSI. Tell us a little bit about why that decision.
The reason I joined UCSI is that number one, the UCSI, the design of the hospital was done by our late Khalid Yusof, so my lecturer before. So he has the experience of building, designing a hospital in UKM, UITM, and he was the one responsible in building the UCSI hospital. But a lot of potential. It's not a shop lot hospital, but it's actually a proper built hospital. But I was looking at the content, so the facilities already there. The operating theatre is one of the largest, spacious operating theatre in Malaysia. Right. So the content. So my role is actually if I have this to grow together with the hospital. Yeah, if I were to join an established hospital, most of the time, the potential to grow is actually very limited.
Sure.
Here is actually an endless possibility to
Right.
grow the hospital because now we have 150 beds. Our intention is to have 1,000 beds.
Oh, okay. So you're running at 15%.
Yeah,
only.
so it's a health metropolis that we are looking at in Spring
Okay.
Hill.
Right.
So there's a lot of potential there, and our next project is actually to have a department of oncology, radiotherapy, and etc. And PET CT scan. Also, all these are in the pipeline. So
Okay.
for us to develop the hospital. And services, I think now looking into services, specialty and subspecialty is quite advanced in Spring Hill Hospital. In fact, for Negeri Sembilan, I think we have all the expertise now. We have a cardiac surgeon, we have a urologist, we have neurosurgeon, and then we have all specialty. So I think that's very promising. But more important is that we can provide good quality of care at a reasonable cost.
Okay. And we all, a lot of us, of course, follow you on your social media. And, you're so busy, you're doing so many things, but we can see the absolute joy when you are in an operation theater.
Oh,
Tell us a
yes.
bit about that.
Well, I think it has always been my passion, to go to the operating room. In fact, when I was offered the deputy post, the first time I rejected it, because I told them I'm a surgeon, so I'm not the administrator. But 3 years later, I was offered at age of 40. Then 3 years later, at age of 43, then I was offered again. Then I reconsidered because I look at there's a gap between management and the ground level, top down, and there's a gap there. And at that point of time, the management do not understand what we do at the ground level.
Okay.
So because of that, I decided that okay, I will take the administrative role as the deputy DG, provided I negotiate with the management then, provided I'm still allowed to practice 1 day a week.
Okay.
So that was my negotiation. So I've been practicing that for 6 years as a deputy DG until the age of 49. Then I was appointed the DG, but I still keep practicing 1 day a week as a DG. So normally my operating day is on Friday, so that I have Saturday and Sunday to follow up the patient.
Right.
And most of my patients, short hospitalization, in 1 day stay, I do the operation today, tomorrow discharge, for example. And again, engage with the patient, follow up with the patient with WhatsApp and etc. Because anything goes wrong with the patient, I want to be the first to be informed, right? Rather than they go to other places. So at least I can advise them what to do, what not to do. So I've been practicing for the last 10 years as a DG. Only during the pandemic COVID-19, operating room, operating theaters all been shut down, and then I stopped practicing for a while. But now back to our clinical practice in hospital.
Yeah, but I mean, during that period where you stopped practicing in the surgery, COVID, which was the most difficult time for Malaysia, and what helped you get us through that period? Because I mean, everybody could see how tired you are every day at 5:30. You were giving reports, which means that you went through everything before you talked about it. Tell us what kept you going at that time.
Well, I think we were the last line of defense. If we fail to defend, then the whole country will be affected. More death and economic impact and etc. So we know that the frontliners we are the last line of defense, and we have to do well. Otherwise, our health system will collapse. So we manage to handle well, and we always fall back on data at that point of time. For example, listen to the facts, science, and data, and learning from the experience of other countries ahead of us. For example, in UK, in China, what they did right and what they did wrong. So that is actually a very important lesson for us, not to repeat the same mistakes they have done. So I think we use the concept of listening to the data, science, and facts, and what been practiced. And that's one. Second is also we fall back on a lot of creative ideas and innovation.
Right.
That means, for example, China can build a 10,000 beds hospital in 10 days.
Yes.
We do not have that kind of capacity, but we have creative ideas and innovation. For example, we can convert MAIPS to be a field hospital, 10,000 beds field hospital within 7 days.
Right.
And to isolate our patient and etc. Because before the pandemic, our hospital already congested.
Right.
So this is something that we can come up with creative ideas and innovation. So every state have their exhibition centers and public hall we can convert to a public hospital, for example. So this is something that we thought of. But more important is the risk communication. As I
Right.
mentioned earlier, when we talk to patient, we explain all the issues and challenges, manage the expectation of our patient, and then win the public trust, patient's trust. And that's the reason why we engage risk communication with the public, because there's during that period of time a lot of uncertainty, and that's where we need to crunch the data, engage with the patient, explain the issues and challenges to them, what to do, what not to do, and indirectly we change the behavior of the patient. More important is manage the expectation of patient and tell them what to do and what not to do, and slowly we change the behavior. How, for example, in terms of the behavior of putting on the mask,
Right.
washing hand, avoid crowded places, confined spaces, close conversation, routine every day without fail. We try to engage and teach the patient. So you can see the public change the behavior slowly because
Right.
they know what to do and what
Yeah.
not to do. This is how I think we use, win the public trust first. And then with the public trust, we try to change the behavior. Can you imagine if public do not trust the Ministry of Health? That's the beginning of the end.
Yes,
Whatever
yes.
you say, it won't go. So at least now the public trusts us, and then we use the behavioral change to change the behavior of the patient, the public, and towards a health-seeking behavior. So, and with that, for example, on the 18th of March 2020, it was the first day of lockdown. Before that, 7th of March, we got a call from my colleague, the Director-General of Health in Brunei, saying that one of the participants from Sri Petaling Mosque came back and positive. So we didn't know there was a gathering of 16,000 people in that mosque. So we went to that mosque. By then it's too late. Most of them have returned to their own state and even own country. So there were about 500 people there, and then we tested all the 500, about 400 of them positive COVID-19.
Oh, wow.
So what we advise the Prime Minister then, when you do not have the vaccine, limited in terms of testing, and there's no therapeutic for the COVID-19 then. So the only thing that we have is we know that this group, when they go back to their respective village and district, they will go from house to house or even a mosque to mosque and preaching, for example, and that will spread the infection.
Sure.
So we told the Prime Minister that perhaps we have to issue the lockdown for 2 weeks, and and advise the public to stay at home, and to limit the movement control order, and then probably we can actually minimize the infection. And during that period of time, we are already using AI in terms of projection of cases, prediction and projection. So our prediction and projection, 2 weeks later and 4 weeks later, there will be a spike of infection.
Okay.
So unless we intervene, then we can flatten the curve.
Sure.
So we intervene with a lockdown, and sure enough, after 2 weeks, and then the Prime Minister extends for another 2 weeks, we flatten the curve rather than to see the spike of the case curve. So we have projection, and then we manage to flatten the curve, which shows that the public empowerment is the key, not only from the point of Ministry of Health, but teach the public what to do and what not to do. But when we succeeded to flatten the curve, and that's where the challenge comes in terms of success leads to complacency, and then complacency will lead to failure again.
Yes.
And then they call for PRN Sabah. So PRN Sabah, well, the cases are already in control, almost zero.
Almost zero.
Then, do you allow? Yeah, preferably not to have the PRN, but they have to have the PRN.
Yeah.
So we have no choice but to advise the government. You have to comply, put on the SOP, put on the mask, avoid crowded places and etc. But that was not comply, and you can see a spike of infection after the PN Sabah.
Absolutely. We're going to take a quick break, come back with more right here with Sri Dr. Noor Hisham, right here on Healthcare Simplified with Manvir Victor. See you in a bit. Hi, welcome back to Healthcare Simplified with Manvir Victor. We're right here in the studios with Sri Dr. Noor Hisham. And Sri, you were mentioning just now, you managed to flatten the curve. But before that, we were talking about the fact that you all use a lot of data.
Yes.
You use AI, predictive analysis. Now, how important is data in healthcare?
Well, I think future of healthcare, we have to rely on data, and during the health crisis, during the pandemic, it was not only the health crisis, it was also a political crisis and economic crisis.
Right.
So we need to fall back on data, otherwise it's not my opinion, but it's the data that, every morning in Ministry of Health, we have a meeting with all our respective departments. And, we discuss a lot of issues based on facts, data, and science again. And with that data, then we try to intervene and also advise other ministry what to do and what not to do. So data at that point of time.
Okay.
And we have a window of 6 months period learning from other countries who have gone through.
Right.
For example, the strategy initially, there were two approaches that we have to look into. Ministry of Health in Malaysia, we have always used prevention and control method.
Okay.
Prevention and control approach. But other countries like Sweden and UK, they started with the immunity approach in that sense, in terms of herd immunity approach, whereby their reasoning is that if the young population, they protect the high risk group, and the herd immunity approach, in the young population been exposed to the virus,
Right.
and when they recover, they have natural immunity, and you get about 80% or 90% natural immunity, that you can actually have the herd immunity approach.
Right.
So that was the two approaches that we have. But we were not sure, it will work with herd immunity approach because we do not know about the virus.
Sure.
Yeah. So if we do not know the virus, it's very risky. Sure enough, for the first 6 months, you can see the young population exposed to the virus also succumb to the disease.
Right.
So that shows that eventually, the first few months, even in UK and also in Sweden, they switched to prevention and control. So for us, from day one, we have been using prevention and control.
Right.
Try to avoid the infection, to be infected, and try to protect ourselves rather than to expose to the virus. So we have been using that, and obviously, in terms of it's not sustainable for lockdowns and etc. because the economic impact is very high.
Sure.
But the solution is that we need to get the vaccine. But unfortunately, I think difficult for us to access to vaccine. Rich country, they buy all the vaccine. Poor countries, sometimes we paid the vaccine, for example, in December 2020, but the vaccine only arrived 6 months later.
Right.
Right? Because rich country, they can afford and then they buy the vaccine. And we learned something very important here. When we procure the vaccine, we procure on behalf of 30 million population in Malaysia. But one of my friend from Austria, during the WHO meeting, informed us that in EU, they only one person negotiate with the company to procure the vaccine on behalf of 30 countries.
Okay.
When you represent 30 countries, big volume.
Right.
When big volume, the cost is much cheaper, faster delivery.
Right.
I think if we have used the platform, ASEAN platform, for example, then we have big volume, we can actually negotiate the better pricing and fast delivery of the vaccine. There's something that we learn, from this pandemic COVID-19. Small countries like Brunei, very limited, option that they have. The company been offer them, this is the price, very high price, take it or leave it, because they have no volume to negotiate.
Right.
So I think it's important for us to come together as a regional platform for us to negotiate the vaccine.
Right.
And this is something that we can learn from the experience and see how best we can pull together the resources for us to procure the vaccine and medicine.
So that's what EU did, and ASEAN didn't do that at that time. Do you think that moving forward, ASEAN can replicate that?
Yes, we have a meeting in NUS. I was called in to represent Malaysia and also representative from Philippines, Brunei, Thailand, and Indonesia in Singapore, in NUS. So we discussed about this pool procurement, and we hope that Singapore and the region, the representative from the region can actually bring this issue up during the ASEAN meeting, and hope we can actually have a discussion and a platform for us to discuss. And it's not purchasing the vaccine on behalf of one country, but to negotiate the pricing for one, for the region, then we can actually bring down the cost.
Because there are about 700 million people in this.
Yes,
ASEAN.
exactly. So even, for example, give you example of dengue test kit.
Right.
Once upon a time, I think there was a spike of dengue infection in our country. And we asked the GP, why are you not testing in the dengue test kit, using the dengue test kit to test the patient whether they have dengue or not? If they have, then they refer the patient to the hospital as soon as possible. Then the GP told us that because the test kit costs about 90 ringgit, 90,
Okay.
and plus the medication consultation is more than 150 to 200 ringgit.
Right.
So they omit the testing. So that's the reason why there's a spike of infection, even fatality. So then we, Ministry of Health, we negotiated with the company on behalf of the GPs, about 8,000 GPs out there.
Right.
So with pooling of resources, public sector and private sector, and you guess what? We managed to reduce the cost of the dengue test kit from 90 ringgit
Right.
to 15 ringgit. 15 ringgit. That's
Wow.
right. Because you have pool.
You have
Then
bulk.
you get bulk. Yeah.
Yeah.
So this is something that we learned, that if we pool together resources, we can bring down the cost.
Right.
Likewise, before I retired, also we have pooled together procurement in 82 medicine in 3 ministry: Ministry of Health, Ministry of Higher Education, and Ministry of Defence. So we pool together 82 medicine per year, and the cost saving is 176 million.
176 million.
That's right. Same medicine, but then because of bigger volume,
Sure.
you can actually bring down the cost. I think this is something that we can, practice and emulate, and perhaps working public sector, private sector, and also regionally. And this is also my discussion with Dr. Tedros, talking about pool procurement. Other countries are doing it in EU, in Middle East, in Africa. They're already pooling the resources together.
Okay.
So if we can actually use ASEAN as a platform, and Dr. Tedros said to me, you need to, basically show that you are able to pool together the resources in your country first. So in our country, we start with Ministry, government hospital,
Right.
public sector, and then slowly public and private.
Right.
And then we talk about regional pooling. So if we can do that, every country have a role to play, for example.
Right.
And also stockpile of medicine. Maybe, snake bite, anti-venom, we can pool one country and then have stockpile in one country in ASEAN, and then another country can stockpile other medications. So we can cost sharing in terms of the ASEAN platform.
Okay.
That is another way of looking into how we can actually work together in this region. And perhaps ASEAN platform is the best, in terms of getting a health minister together and to implement this pooling of resources in training and also in procurement.
Okay. So now Malaysia is the chair for ASEAN.
Exactly,
for the next
that's
couple of
right.
years.
Yeah.
So this is something that they should seriously consider.
I hope so. Yeah.
Okay. Now I want to ask you about preventative health, because with skyrocketing costs, healthcare has gone up.
That's right.
Are we doing enough in prevention? And where can we move ahead to increase that?
Well, I think our focus is to shift curative care to preventive care.
Right.
And that's the most important. If we can actually age, for example, today, if you are 60 and above, you have at least 2 comorbidities.
Right.
When you are 70 and above, 50% of the population have at least 3 comorbidities. So above 60, 50% have 2 comorbidities.
Okay.
Above 70, 50% have 3 comorbidities. So when you age, we want you to age healthily, Otherwise the cost of care will be increased higher. So we need to focus on preventive medicine, and how can we focus more on healthy living, and to make sure that we can actually reduce the cost of treatment and etc. So prevention, I think we need to focus more in our allocation. 75% of the allocation of healthcare is more towards curative in Ministry of Health.
Right.
So I think we need to actually spend more in preventive. But the issue is, because preventive, it takes the long term in terms of the outcome, right?
Sure.
So it must be sustainable. But when you look into the data, it's not promising at all when you see diabetes, hypertension, obesity is increasing, right? Despite what we have done. But some will argue, if we have not intervene, it will be higher, right? So
Okay.
I think we need to, invest in preventive medicine. I think that is the
And where should that investment be? I mean,
education. I think that's a very important. Healthy living education. Teach the people what to do, what not to do.
right.
Continues to engage, reduce salt intake, reduce sugar intake, and avoid risk factors like smoking, vaping, and all that. So all these initiatives must be taken into account, and the healthy living, and these are the key.
So you've been working globally as well. So you see that in some countries in ASEAN, they already have something they call a sin tax, where
Yes, yes,
they tax alcohol, they
yes.
tax smoking, all
Right.
this, and that money I assume goes directly into healthcare.
Yeah, but
How?
when they tax, the money goes back to the consolidated fund under MOF, so
Right.
not to Ministry of Health.
Okay.
But we hope that more action can be taken,
Right.
and regulation in place to control, and invest in preventive medicine.
Okay.
Mm.
So yourself being a surgeon, and you've seen obviously patients obese, and because of that they've got other multiple
Yes, that's right.
comorbidities and
Yeah.
all these issues. Are you one of those who would support taxing sugar or smoking? And
But I think it's not the tax only, but we need to educate the public.
okay,
For example, reduce sugar, no sugar in our coffee and tea, for example,
right?
and then can reduce that. And we also realize that in my field, I'm a thyroid endocrine surgeon, so I see a lot of thyroid, for example. One of the reasons is because iodine deficiency. And very high prevalence, about 22% in Borneo, in Saman Sarawak.
Okay,
And why? Because there was a study done shows that in Borneo, when they take the sagu and all that,
right.
there's without iodine.
Okay,
So when it's without iodine, the goiter, you form goiter, iodine deficiency goiter.
okay,
So now I think we have started the program, iodinize the salt, for example, iodine with salt, and then that will probably in the long term will reduce the large goiters in our country. So
okay.
in some of the successful country in the West, their salt has been iodinized, and then you can see the reduced. And we don't take seaweed that much as compared to Japan.
Sure.
So iodine is less in our diet, and that's the reason why I think we need to actually highlight on that. Although we have the sun, for example, and but we many of us still we are short of deficiency in vitamin D,
Right.
because we try to run away from the sun, right? So unless we expose to the sun, and then our skin can convert the vitamin D.
Right.
So there's actually a vitamin deficiency in our body. So these are the preventive measures that we need to look
Sure.
into it and see how best we can enhance our health, better health in future.
So preventative health is important. And earlier you mentioned that you're also chancellor of university.
Yes, yes.
And as you see that the next generation of doctors coming out, what really needs to change so that when they take over with IT, with AI, with digital, and these new integration, how should we change the way we teach doctors?
No, I think now we have the tool, so in terms of AI, in terms of the knowledge is all accessible now. It's
Okay.
how you are able to use the knowledge and engage. I think the first thing what I would like to teach the medical students and the young doctors is, improve their engagement with the public and
Okay.
also the patient.
Right.
So that's the key, in good engagement. And also how to use the tool.
Right.
Those days we try to remember every facts. Today we don't need to. You need to train yourself how to use the tool that we have.
Okay.
Whether it's the AI, whether it's the IT and etc. So
Okay.
how to use the tool is more important.
Right.
So you don't need to remember everything,
Right.
but you can be assisted by all the tools that you have. But you still need to lead in terms of how to use it, for the good. But it's actually a double-edged sword, of course.
Right.
You can do good, you can do bad things from that. But I think teach them how to use for the betterment of the healthcare in this country. I think that's the key.
So I've had a number of doctors that I know who don't like patients who come in who are advised by Google.
Mm.
What's your thoughts on this?
So, for example, now you look into the tool that number one is empower the professional.
Right.
So, empower the professional now with AI, you can actually helps you to read the images, like radiology and all that. You can read, and then you also you try to endorse the findings. Even pathology, for example, they can read the slides for you, but eventually you need to endorse it. And retinopathy, for example, we already have this retinopathy to see your retina.
Right.
But now there is actually a program AI to read for you as well. So if we can interlink with the two, reading and also interpretation,
Right.
then you can actually screen
Right.
the AI. Those days, I think the X-ray we have to send to another center for them to report, and then they come back to the reporting. But you don't have to do that now. With AI, you can actually get that report now. So that is to empower the professional. And obviously the paperwork, with AI, initially you talk to the patient, then you have to type everything down.
Sure.
So now you don't need to, you just talk to the patient, everything been summarized already, in the center. So, and chat box, now you use the chat box. Call up the hospital or call your line. There is actually someone talking to the patient, to your patient. It's not you. Sounds like you. It may look like you, but it's not you.
Okay.
But you can advise the patient accordingly now.
Okay.
And you know when to refer to the doctor. So many hospitals are using chat box now. Here in Malaysia, in terms of private hospital, I think more than 100 private hospitals have chat box now in terms of engaging with the patient. It's not a person talking to you; it's a machine talking to you.
Right. Yeah. Absolutely.
But they know when to refer you to the private to see a doctor, to talk to the doctor. So I think something that you can do that. Now in the meeting, you don't need to summarize now. You can actually summarize.
Yes.
Likewise, when you engage with the patient, you can summarize everything now.
Right.
And then in your notes. So that helps us to have more time to see patient.
Right.
And in paperwork, less paperwork for us.
Right.
And that enhance how we take care of our patient.
Yeah.
So this is improving the system in terms of management.
And I've seen that in your career in the government. I was amazed that in the midst of COVID, we used to have 1 o'clock in the morning conversations.
Yeah, of course.
You understand? Because on top of that, and I used to feel bad. You're talking to me on the phone because I thought you need to sleep because you have to get up and. But you were just mentioning things. You had data at your fingertips because all those tools were working for you.
Yes.
While you're resting or doing something else.
Yeah, so during the pandemic, I have access to all the data center, for example, the IMR, and then to public health, hospital, I have access to them. So they feed me with the data, and with that data, I make decision based on that data. And then they can advise accordingly, and we endorse it, and then we make decision. So it's a continuous engagement with facts and data. So you will never go wrong, but you may go wrong, but then data at that point of time.
Yes.
So you fall back on data, how many emission, how many discharges, and etc. So it helps us to make good decision based on facts and data.
Yeah. I was one of those people that I remember when COVID happened, and because I know you and we've had that relationship, I knew that you were the right person. You were the right person because you had, you were already always talking to us about data, getting this, getting that. For years, you've been talking about it. Then suddenly, you're the forefront of this, where you have to make decisions, split-second decisions that, at the end of the day, it's lives at stake. You had it, and it's unenviable task that you had.
Being a leader, you must be able to make decisions.
Yeah.
Fast decision. Being a surgeon, you have to make decision, operate or not to operate. Right. So you cannot delay the decision. No decision is already a decision. Right. Delay decision is already a decision.
Yeah.
So you make a fast decision so that we can intervene as fast as possible.
Right.
And the intervention that we give, we can actually flatten the curve.
Right.
So I think that is the key for us. In healthcare, and we need to make right decision.
Right.
And if you fall back on data, most of the time you make the right decision. Right.
So this is going to be a slightly controversial question. If another pandemic hit us today, have we learned enough from what we have done to do better globally?
Yeah, but I think most of us have forgotten about all the experience that we have done.
Right.
For example, during the pandemic, we have a National Security Council that meets every day. And also Ministry of Health, we have a meeting every day without fail, virtually as well as face-to-face meeting. Some will be attending the meeting virtually. So we have a meeting 8 to 9 and 9:30, in terms of spending time to look into the data, the issues and challenges. And then from 10 o'clock, we have a meeting under National Security Council, chaired by the Prime Minister or Deputy Prime Minister then.
Right.
And we will table the facts and data to other ministry, and hopefully implementation can be done at the respective ministerial level. So that is how we actually communicate and practice whole of government and whole of society. But unfortunately, I think there's after the pandemic, we don't see the National Security Council to come together again,
Right.
To have a lesson, to look into all the lesson learned,
Okay.
and how to strengthen in terms of the National Security Council,
Okay.
and etc. It's just like floods every year.
Yeah, yeah,
floods. Action been planned, and then so that we can actually be ready in the next pandemic. That is something that I think, and most of the public also have forgotten about the pandemic.
Okay.
So if we forget, then probably we'll repeat again all the mistakes that we have done in time to come.
So my final question to you is, Tatri, knowing what you know right now, being involved globally, locally, what's the future of healthcare in Malaysia in the next 5 to 10 years like?
I think the healthcare costs will continue to escalate. There's no doubt about that. But more important, how do we mitigate the escalating costs? So we need to get all parties together in terms of all the players together and strike a balance between the cost, life and livelihood in the health and economy. So we need to maintain and mitigate the costs, but continue to provide good quality care.
Right.
So in terms of human resource, in terms of training, every field, I think we have to be serious on that. Otherwise we are losing our people, our staff to other countries, and more important is that there must be an overarching view of healthcare to integrate the public sector and the private sector.
Okay.
We have been talking about healthcare transformation for the last 45 years, and we also have white paper in place.
Yeah.
But I don't see the implementation yet, So
Yeah.
white paper has been approved by Parliament.
Right.
Everyone agrees that we need to transform.
Yeah.
But the issue is, how are we going to transform?
Yeah.
What are we going to transform? When are we going to transform?
Right.
Still unanswered.
Absolutely. I mean, as a patient, I've been in this space for a number of years. The white paper to me is invisible because as a patient who navigates public and private healthcare for my own care, I don't see anything happening. And everybody has been talking to me about this white paper, but when I don't see it, it's invisible to me. It's invisible to the next patient, the future patient. Nothing seems to be happening, which is very detrimental to the future health of this country. But talking about the future, where do you see our next generation of doctors? I mean, you're at Cyberjaya, you're at UCSI. Where do you see them going? Are we going to get good doctors out?
I think we need to continue to train our doctors, but more important is to retain our doctors in our health services. The pooling factor has been there, whether private sector or regionally, but many of our staff resign, whether the doctor, nurses, allied health, is because of the pushing factor.
Push factor. Okay.
So we have to address the push factor first. Why are they resigning? We have to recognize them, value them, and have retention packages for them. And, we need to, have innovative, creative ideas to retain them in service.
Right.
So retention package is important, how we are going to do that. But failing to understand this issue of pushing factor, that is why many of our doctors and nurses resign to other countries, for example.
Absolutely. Well, thank you so much for your time, Tan Sri. Wishing you the best. And obviously, for those of you who are keen, he's at UCSI Hospital, which is in Spring Hill. You can check that up on Google. Follow him on his social media as well. And, go see him there to find out. I am amazed at your Rayat wing in a private hospital, and I'm wishing you the best. I will definitely send some friends over there or people that need your help there, because I think that you're doing great work. You always have been doing great work, and there's so much more to come. Thank you very much for being on Healthcare Simplified with me. It's a pleasure as always. Any final words from you?
Thank you for having me this afternoon. But more importantly, I think we need to work together, public sector, private sector,
Right.
and then optimize the resources of the country, not sector.
Right.
How can we optimize resources in terms of manpower, in terms of managing patients together? And certainly, if we can optimize both sides, I think we can improve our healthcare for better care for tomorrow.
Well said. Well put. Thank you so much. And once
Thank you.
again, Tan Sri. That's it from us right here on Healthcare Simplified with Manvir Victor. We'll see you back again next week. See you then. Bye.